Thank you very much for the invitation to speak and for the wonderful talks already this morning. Emma, that was incredible. Your bravery and courage and honesty is inspiring. Let me make sure for some reason this jumped to the wrong part of the slide. Just need to... All right, here we are. So yes, I've been asked to talk about epilepsy, and I'm going to try to stay pretty focused towards that. There's a lot to cover for 30 minutes, so I'm not getting into other aspects of CDD during my talk, but I think a number of the other talks today are going to touch on other aspects of what you all face and have to deal with. I have funding from IFCR and NIH, and I have consulted with various groups about CDKL5 and various other genetic epilepsies over the years. So what am I primarily talking about? Two big buckets. What does epilepsy look like in CDD, and how do we treat it? So I like to start this talk with a bit of a primer about seizures, seizure types. What are we talking about when we throw around all these different seizure type terminology? You guys all become experts on this, unfortunately, over time. And I want to make sure we just sort of level set for that. So when we talk about seizures as epilepsy doctors, we think about them in two main buckets. We think about them as either generalized, meaning they're sort of showing up in the whole brain or in broad parts of the brain all at one time, or we think about them as focal. Focal really just means it's starting in one specific part of the brain, and then it may spread from there. So when you have a generalized seizure, that could look several different ways. It could look like a generalized tonic-clonic seizure. This is the classic, what everybody who's unfamiliar with epilepsy thinks about when you think about epilepsy. It's a full body convulsion with stiffening and jerking. If we break that up, it tells us about what the other terms mean. So tonic just means stiffening. Clonic or myoclonic means jerking. So a generalized tonic-clonic means full body stiffening and jerking. You can also have components of that by themselves. So you can have a generalized tonic, meaning whole body stiffening, but that there isn't that much jerking. You can have just jerking. So you can have myoclonic seizures. Usually, those are single jerks that happen. They can happen in clusters, or they can happen by themselves in isolation. You can also have a rapid set of jerk, 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 jerk. That would be called a clonic seizure. Finally, you can have absent seizures, which are short staring spells. These can be tricky ones because there's lots of other reasons that kids and patients with CDD stare. And sometimes it can be hard to tell, is that a seizure or is that some other reason for staring? And then the last one in the generalized column is atonic. So the atonics are the opposite of a tonic. So instead of the whole body getting stiff, the whole body goes limp. These are also sometimes called drop seizures. You could think of these as like cutting the strings on a puppet, just whoop, whole body loses tone. What do focal seizures look like? Well, the reality is, depending where they start in the brain, they can look lots of different ways. So that part of the brain and how it functions is what's going to determine what does that seizure look like. Usually they're not the same on one side of the body compared to another, so there's some asymmetry there. But they can spread through the brain and become generalized, not at the beginning, but over time. And so they may end up looking similar to a generalized tonic-clonic seizure. And then there's this other group that we say is kind of other because it doesn't fit neatly into generalized or focal. And sometimes it kind of involves the whole body. Sometimes it's off to one side or asymmetric. And that's epileptic spasms. And again, tonic seizures can look this way. So you can have one side more affected than another side. Epileptic spasms are really just short tonic seizures. So the short stiffening seizures, they tend to happen in clusters. And when I say short, I mean 1 or 2 seconds. stiffening and relax, stiffening and relax. They almost look like myoclonic seizures, like little jerks, but they last a little bit longer, 1 or 2 seconds, just this brief stiffening phase. So that's just sort of general terminology. I think this is important because it helps you to communicate effectively with your neurologist or epileptologist about what you're seeing and about what you're trying to treat. So just to give a little bit of primer on and visualization of what we're thinking about, not trying to turn everybody here into the ability to read EEGs, but this is what we're looking at when we're seeing an EEG for a patient. And this is how we think about it. You see a little map of an individual here, a little cartoon. This is the nose and the ears. And this is where we put all of the little electrodes on the head. And what that translates to is that every line on this screen is looking at one electrode compared to the next electrode. And it's comparing what is the electrical activity between those two electrodes. And we divide this up into things that are on the left side of the brain and things that are on the right side of the brain. And then we can kind of localize where are we seeing differences. So when we're thinking about generalized versus focal, this is kind of a way to think about it. Generalized, you can see these spiky things, which are abnormal electrical activity that corresponds to seizures or risk for seizures. This happens everywhere at once. So across all the leads on the head, we see this change very rapidly showing up across the whole brain. On the other hand, you could see these smaller spikes here that are just in certain areas. So these are focal, these are generalized. So how does that look in CDD? Well, this is from a recent review by Helen Leonard and us that sort of said, what do we know about this from a variety of different studies that have been done? So these are 5 different studies where they've tried to describe what do seizures look like in CDD and at what age. And we divided it up into 2 different groups, sort of initial seizures, so the first couple seizures that you start to see, and then seizures that show up anytime throughout life. And what we see is that you can have lots of different types of seizures. So all the seizures that I talked about, you can see in CDD. You can see clonic, myoclonic, generalized tonic-clonic, spasms, tonic, and focal. We also talked about focality, and this means it's sort of one of these other ones, but maybe it's asymmetric or it's a little bit focal. And so you could think about like it's a tonic seizure, but it's not totally symmetric from side to side. And that's actually pretty common also. There's also this terminology, HTSS. That stands for hypermotor tonic spasm sequence. Hypermotor is a seizure type that usually starts from the frontal lobes in the front of the head. And it's sort of lots of movement of the body, but not in any sort of organized way. It's sort of quite random and can be a little bit like agitation. It may include getting up and walking, doing repetitive activities. But then from that, it moves into a full body stiffening tonic seizure, followed by a cluster of spasms. And often you have tonic seizure, another tonic seizure, another tonic seizure, and the tonic seizures get shorter and shorter. And eventually they're only a few seconds long, which really counts as a spasm now. And now you have a cluster of spasms. And this sort of combination of different seizure types within a single episode is pretty common in CDD and is a little bit unique compared to other seizure types, other causes of epilepsy. It's not completely unique, but it is something that for me as an epileptologist would make me think, I wonder about CDD. If a baby was having this or a toddler, and we didn't have a diagnosis for them already in terms of why they had seizures. So then we could think about current seizure types. So this is sort of initial, and this is something that shows up at any point. And again, we see all those same seizure types. And some of this was broken up a little bit to sort of say, is it this classic hypermotor tonic spasm sequence? Or is it something that's sort of like that? It has the spasms and the tonic seizures, or the tonic seizures and spasms, but maybe not in that exact order. Maybe there's a hypermotor, maybe it's not. And we actually saw that that was pretty common as well when we looked at patients who were seen in 3 of the centers of excellence. And so this is this combined or like HTSS. And then we also wanted to ask, what about honeymoons? And I'll talk a little bit more about this. And this means, like, is there ever a period where we don't have seizures? So I think the big takeaway from this busy slide is every type of seizure is possible in CDD. One study showed that it's almost 3 different types of seizures that patients are dealing with at any one point in time on average. And tonic and epileptic spasms and this sort of combination of seizures are probably the most frequent type of seizures. Most patients have these type of seizures in the 60 to 80% range. So we're going to talk a little bit about these different types of seizures. And then just to sort of delve into one part of this, I'm not going into a lot of information about what EEG backgrounds look like and that sort of thing. But infantile spasms are a little bit of a unique seizure type. And when you see epileptic spasms, which is the seizure type, and infantile spasms, which is when it occurs in babies, then you usually see a background change called hypsarrhythmia on the EEG. And that's not during the seizures, that's in between the seizures. If you take every other cause for infantile spasms, which there are many, many causes, about 80% of patients will have hypsarrhythmia on their EEG. We see that in CDD, that's only about half. And part of the reason that's important is because that's a really good telltale sign for us on the EEG that this is what's going on. If we see hypsarrhythmia, we think infantile spasms. So if we don't see it for half of our CDD patients, sometimes that leads to delays in making that diagnosis and understanding the type of seizures that those kiddos are dealing with. When do seizures start in CDD? This is from 93 patients seen across 3 centers of excellence. The age is over here on the left. And this first line is 10 weeks. And then this is just how many patients have had a seizure already by that point in time. And what you see is the vast majority have had a seizure already by 10 weeks of age. And our average or sort of median age is about 5 weeks. So it starts really early in life. There are some that start a little bit later, but the vast majority are really starting in the first weeks of life. What about this question of whether seizures ever get under control? Do we get a break from seizures ever? This is an interesting way of looking at that data. And this is from Helen Leonard and Jenny Down's group, looking at almost 170 patients that they have in the ICDD database. And every line represents a different patient. And some patients we have more data on because they're older. Some patients we only have a little bit of data on because they're still younger. And the gray lines are everybody who's having seizures. The blue lines are, we had a period of seizure freedom, but now seizures have come back. And the orange lines are, we've had a period of seizure freedom, and at least when they stopped recording and when they did this data cut and analyzed the data, those individuals were still seizure free. So what you can see is there are some orange lines, and there are some patients who actually have been seizure free for many years. It's not the majority of them, but there are some. We also see that there are many patients who have blue lines and are seizure free for a period of time, but often the blue lines are shorter, and we don't keep that seizure freedom. Another way of looking at this data, which this is now from the Centers of Excellence data, but we sort of analyzed it a little bit different, is we said, what if we bin this into how long someone is seizure free? 1 to 3 months, more than 3 months, more than 6 months, or greater than 12 months. All different types, anything more than 1 month, we get about almost 45% of patients have a period of seizure freedom at some point that is at least a month long. 3 months, 6 months, pretty common. Greater than 12 months is more rare, so maybe about 12 to 15%. but staying seizure-free in our data was only about 5% of patients. And in Helen and Jenny's data, that was about 6.5%. So it's pretty consistent that seizure freedom does occur. Unfortunately, it's usually not forever, and seizures often come back at some point. Another way that we can think about epilepsy and CDD is sort of summarized on this slide. There is a lot on this slide, and I apologize, it's probably quite small. I'm happy to make these slides available also to everyone in the community for use later. This is from a recent publication from William Hong, led by himself and Heather Olson at Boston. And we could think about sort of 3 different stages of epilepsy and how they evolve over time. And so the first one is sort of in the first 2 to 3 months of life. Usually we're seeing generalized tonic-clonic, generalized tonic or asymmetric sort of focal seizures and spasms. And sometimes that, what we're calling here sequential seizures, which is that hypermotor tonic spasm sequence, which is a mouthful. And the idea there is not just that it comes in any particular order, but that there's this combination of multiple seizure types that sort of happen in a sequence. So that's why we're calling them sequential here. As I think one of the things that's important to realize is that we do see that in some cases, EEGs are actually look pretty good. They look normal. I think that the challenge here is that if the EEG is normal, then sometimes families are told, you know what, I think the seizures are going to stop, we're going to get them under control, and give sort of a nice rosy outlook. And then families say, okay, if we can just stop these seizures, everything's going to be fine. And I think that that can be a bit challenging then when they get a diagnosis of CDD, if genetic testing comes back, and all the things that they're told about what that means. And so this is a little bit challenging sometimes that we see that. We don't always see a normal EEG. We also see sort of slowing, or we can see some epileptiform activity like I showed on those earlier EEGs that suggests that risk of seizures. The second stage is typically characterized by spasms, even if there were other seizure types earlier, and we see a lot of epileptic spasms. This might be 6 months to 3 years of age, somewhere in that range. And then sometimes there will be other seizure types that were under control, but they come back during that time, and we often also see the sequential seizures. We see more abnormalities on the EEG usually by this stage, where we'll see, again, hypsarrhythmia in about half of patients who have epileptic spasms. But even in those that we don't see hypsarrhythmia, we do tend to see some abnormal slowing of the EEG and more of this epileptic activity that tells us that risk for seizure. And that would be what we would expect with somebody with epilepsy. And then sort of the third stage is moving into sort of, we're just struggling with seizures. We can see lots of different types of seizures. The background on the EEG is often abnormal, and we are sometimes being lumped into a category or syndrome called Lennox-Gastaut syndrome. And that really says we have multiple seizure types, including drops and tonic seizures and spasms, and we see these abnormal EEG backgrounds. So many patients who have CDD fall into the category of Lennox-Gastaut syndrome, which is just a description of types of seizures in EEG background. Not all patients do. There are also lots of other causes of Lennox-Gastaut syndrome that we have to be careful about, that Lennox-Gastaut is not one thing, and CDD is only one type of epilepsy you can see in Lennox-Gastaut syndrome. And the sort of corollary to that when you have infantile spasms is West syndrome, which is another term for infantile spasms. The other thing we see is that the honeymoon period, or the period of seizure freedom for a few months or longer, tends to come on during these late infancy period to sort of toddler period, 2 to 11 months with a median onset around 2 years, and then a duration of sometimes months to sometimes a few years. This is a general description. Lots of patients don't read the book, they do different things, and this is highly variable across CDD. So I don't want to take this as just, this is gospel truth for everybody who has CDD. So what about that question that was raised in the last talk? Does the specific gene change influence the type of epilepsy? Not really. As Dr. Eubank said very accurately, we haven't been able to find great connections between the area of the gene where a change is, the type of change, whether it's a frame shift or a missense or a truncating change, and the types of seizures or the seizure severity. We are still trying to dig at this and see if there are some associations. There's some things that say, well, maybe if it's late in the protein, as Dr. Eubank suggested, it's a little bit less severe, but it definitely doesn't hold true across the entire process. All right, so epilepsy treatment, switching gears a little bit now. So epilepsy treatment is hard. That's the reality with CDD. It is challenging. But I've given this talk a lot of times, and we used to not have any data to really help with guiding this or telling us what sort of things might be helpful. And so it's pretty exciting that we actually do have some data now, and I'm going to present that data and try to sort of summarize it and make it digestible for everybody. All right, so this is, again, from William Hong and Heather Olson's recent review. And this is combining data from a couple of different sources to try to answer the question specifically about infantile spasms. So infantile spasms for epilepsy as a whole, not just for CDD, we often treat differently than if we are treating other types of seizures. And there's certain meds we tend to use for infantile spasms. So I just want to sort of frame that as that's why we're talking about this in a different bucket than the rest of seizure types and epilepsy as a whole. And we'll talk about that, the rest of epilepsy in a second. So what Heather and William managed to do here is sort of say, okay, these are our 4 main ways that we tend to treat infantile spasms. And what they're doing here is comparing CDD patients to a big database of all causes of infantile spasms called the NIST database, the National Infantile Spasms Consortium. And that was like a 30-center consortium that combined data. And so they had, almost 400 patients here that they were able to look at treatment outcomes. And they broke this down into your early response in 14 days, 2 weeks to these medications. Ketogenic diet is looked at a month because usually ketogenic diet doesn't work that quickly. It doesn't work in 2 weeks, so it's unfair to sort of use the same time frame. And then we look at it at 3 months. And what you're seeing is the percent of patients that have had a response to that medication. And you can see that there are decent number of patients, 24%, 12%, 27% that are responding to these medications in CDD, and 20% again here for ketogenic diet at 1 month. You can also see that when you look out to 3 months, unfortunately, many times this treatment effect is not holding. So these are small numbers. You can see really tiny, 0 and 8. So it's only 8 patients and 6 patients we're talking about here. This is not good enough data for us to make firm conclusions, but this tells us, okay, we sometimes get a benefit early on, but we don't tend to keep that benefit. These first 2 are types of steroids. We don't use steroids a whole lot across all of epilepsy, but we do use it in infantile spasms as often the first-line treatment. And in this case, what we're seeing is that we sometimes get a response early, but we tend to not have that response hold over time. Vigabatrin, we also sometimes get an early response, and it holds a little bit better, even though it doesn't hold perfectly. Ketogenic diet, again, early response, and it holds a little bit better, we think. Well, if we compare that to all causes of infantile spasms, unfortunately, the depressing news is that generally speaking, other causes of spasms respond to these treatments better than CDD. I think this is important, not because it should take away hope that we're not going to get these under control, but because some of these treatments actually have significant side effects. And we need to understand whether there's going to be significant benefit from these medications if there are significant side effects, because everything is a risk-benefit ratio. And so this sort of tells us CDD probably doesn't fall into the same category as every other type of infantile spasm in terms of likelihood of benefit from our typical treatments for spasms. But I want to caution there that this is not perfect data. These are small numbers, and it's not our sort of highest tier quality data. This is sort of looking back at patients. And so it's subject to some bias, so we need to be careful. So how would I summarize treatment for infantile spasms? Standardized treatments don't tend to work that well. We don't have clear, better alternatives. So I don't want to abandon standard treatments necessarily, but we should be thoughtful and considerate about balancing potential side effects and benefits. And maybe the data we have now suggests that vigabatrin and ketogenic diet is something we should think about earlier, either in addition to or instead of steroids. And I think that's something that we're still sorting out. What about treatment of all other types of seizures? So I'm just going to orient you to this really busy slide that is from that same source. Again, Heather and William have done a great job pulling all of this together. So we have different study types in this first column. And so as we go along, we're looking at different studies that have been done, some with caregiver surveys, some by looking back at treatment that has been done for CDD patients and how well did it work. I think it's important to realize that looking back part. This isn't perfect data. Sometimes our memory or our documentation of how well it worked is not perfect. So there's bias associated with that. And it's not a sort of randomized control trial, right? Where we can say, did this work when we controlled for lots of different reasons that we could get confounding or mess up our data. And so this is a low quality form of data, but it is some guidance for us about what's going on with CDD. These are types of studies on the left column. Across the top, we see a bunch of different seizure types. These are abbreviations for different seizure medications. And these aren't all the seizure medications, but these are some of the big ones we tend to use a lot. And so this gives us a nice representation across a broad group of seizure medications. The second column is talking about how did that study define success? So 50% reduction in seizures was the threshold that we're talking about for several of these. In the caregiver survey, there wasn't that clear definition. This was sort of, did families feel there was a benefit? There's also a time frame. So 50% at 3 months, 12 months, greater than 50% just in general, 2 weeks, 3 months. So it's a threshold for how much do we reduce the seizures and for how long. And when we sort of piece this apart, what we can see is in this 50% for 2-week column, we get some decent numbers. We get into the 40s and 50% of patients getting that 50% reduction from any number of these medications, which isn't too bad. Unfortunately, when we take that same group of patients that had benefit and we said, what about at 3 months? We see these numbers go down. So still some of them are in the 20s and 30s, which is not bad, but it's not as good as it is in the first 2 weeks. So there is this sort of early benefit that we get from many meds, but wears off over time, unfortunately. We also see that when we take that out to 12 months, we see generally single-digit numbers. Doesn't matter which medication you're talking about, we are generally seeing that the percent reduction in seizures is relatively low in the long run. That means no one med is necessarily working better than another one, and we get some benefit for a period of time, but that usually wears off. What about how did families feel about it? Well, there's actually better numbers here in some ways, that many families in a survey felt that certain medications were actually giving them a benefit. So this means when we don't hold to the standard of 50% reduction in seizures, maybe medicines are actually doing a little bit better. That might be less intense seizures, shorter clusters of seizures. Maybe the seizures aren't having as big an impact on that individual's ability to participate in therapies or do their normal daily routine. So better, that's good. What about the trials that we have? So a clinical trial is generally going to be better data than what we're going to have from just looking back at how we did with seizures. This first one, though, is actually looking back at data. So this is cannabidiol, and we're looking at patients with CDD who had a 50% reduction. And we're talking about something like 30% for 2 weeks and 20% for 3 months, had a 50% reduction in seizures with Epidiolex. So I included this one here because this was sort of a standardized approach to trying to get at the answer of how cannabidiol or Epidiolex is working. And this was one of a few studies that looked at this, but this is the one specific to CDD, not grouped in with a number of other types of epilepsy. We have one randomized controlled trial that has been done. That means some patients get placebo or a sugar pill, some patients get the actual medication. We see how they do and we compare directly. And this is our least biased data. This is our highest quality data that we have. And that was for ganaxolone. And we saw a 32% reduction in seizures. I think that's actually interesting. Part of what we're saying here is even for this, which was considered a successful trial and has led to FDA approval of this medication, for many patients, we didn't hit that 50% reduction in seizures. So some of these lines that we're drawing in the sand are a bit arbitrary. And I think the point here is that many patients had a reduction in seizures, which is hard to do in CDD. And if you compare that to the placebo, only 4% reduction in seizures for the placebo group. So seizures are hard to treat. This was statistically significant. And I think that this is a tool in the toolbox now. And that's why it was FDA approved and will be available to patients, at least in the US, I think, in the coming months. There have been other standardized trials, meaning they're planned, we do them prospectively going forward, not looking back, but they're not randomized and they don't have a placebo arm. And these next two fall into that category. And so these are phase 2 open label trials is what we call them. And that's been done for fenfluramine and for soticlestat. Soticlestat is also TAC935 is another name that people have heard for it. So fenfluramine, this was a really small study, 5 patients, but they had a really big reduction in seizures, 90% median and 71% for myoclonic seizures specifically, and 55% for tonic seizures. This is really exciting early data, no control group, and really, really small numbers with 5 patients. So we have to take this with a grain of salt and be very careful. And this is one of the reasons that this company has now decided to do a phase 3 trial, so a randomized controlled trial to see how well does fenfluramine really work when we put it to the test, bigger number of patients and comparing it to placebo. So I think it'll be interesting to see what those results look like. I apologize, I'm not clicking through, but I should have. So that's the one we just talked about. And then last one, second to last one, soticlestat here. This was again, open label, 12 patients, so still small numbers and a 14% reduction overall. That was very mixed. Some patients got a significant benefit, some patients didn't get a significant benefit. This company is not moving forward with a phase 3 trial for CDD specifically, but they will do a phase 3 trial for Lennox-Gastaut syndrome, which, as I talked about earlier, many patients with CDD can fall into that category. So that may be an option for some patients. And then finally, adalurin, which is sort of an attempt at changing the way some of the gene is modulated, was also performed. And this was actually a phase 3 randomized controlled trial. And unfortunately, it did not show improvement in seizures at 12 weeks. So what about non-medication treatment for seizures? There's three ones we can kind of think about here: ketogenic diet, vagal nerve stimulator, and deep brain stimulation. Ketogenic diet is one that we have some data around. Again, this isn't the highest quality data. This is looking back data. And we see that 50% reduction in maybe 20 to 40% of patients. In CDD, that's pretty good. That's not bad. And so actually, I think ketogenic diet is an important tool that has the potential to be beneficial for many patients with CDD. VNS, or vagal nerve stimulator, this, for those who don't know, is a little pacemaker-like device that's put underneath the skin in the chest, and a little wire that's put into a vagal nerve in the neck. And that vagal nerve is like a big highway that communicates between the brain and our organs in our body, and it's a two-way road. So it sends signals up to the brain and it sends signals down to the body. And we put this electrode on there and we start buzzing it. And this treatment's been around for several decades now. Buzzing that signal up to the brain, for some reason that we do not understand well at all, seems to reduce seizures for all types of epilepsy. Generally, we talk about, not in CDD specifically, a 50% reduction in seizures for 50% of patients, right? So this is not a home run sort of device. This isn't like it's going to stop seizures completely, but it can be helpful in reducing seizure burden and maybe reducing the amount of medicines that are needed. And what we see in CDD, again, from not high quality data, but decent, is that at least some patients are getting reduction in seizures, and that's actually not a small number. So a couple of ways that we looked at this: 50% of patients or more might be getting some reduction in seizure, shortening of seizures, less intense seizures, so some sort of benefit from it. So again, I think that this is a reasonable tool to consider in trying to combat seizures in CDD. Deep brain stimulation only recently has started to be used, at least in the US, for epilepsy specifically. It's been used for other movement disorders and Parkinson's disease and things like that. As far as I am aware, we don't have any data for CDD specifically. I think deep brain stimulation we often think about as being in this sort of VNS category of, it can help reduce, but it's not going to necessarily stop them. And it may be something that we start to see used a little bit more over the coming years for CDD to think about. So how do I sort of summarize treatment for epilepsy and CDD and how we put all this together? Well, this is a risk-benefit ratio. This is a balancing act between side effects and treatment effect. And so if we're trying to control seizures on this side, that means we're trying to go for a goal of less seizures, less impact from seizures, but we also are trying to minimize hospitalizations, long post-ictal periods or recovery from seizures. On the other side, we have to balance that with the effects of the med themselves. We want kids smiling, walking, interacting, having a good time, functioning at their best. We don't want patients to be in the place of just being zoned out, sedated, slow, struggling to function, causing more problems for sort of GI and tone issues and things like that. And so we're balancing the side effects or potential side effects of medications with seizure control and trying to get to that copacetic place, a reasonable place where seizures are maybe not perfect, but they're pretty good, and side effects aren't perfect, but they're not too bad. And that's where we have to go for. And that is an individual discussion with your provider to talk about these things and to go after goals. What I think is important here, as we summarize epilepsy treatment for CDD, yes, CDD is typically associated with very severe epilepsy. It is hard. It starts early and it is hard to treat. There's no one medication that works best for every patient. And unfortunately, that means there's trial and error. And we have to sort of work through different things to find what works for that individual, because different things are going to work for different individuals. But don't lose faith. Don't get too discouraged by that. Keep tweaking things. Because as we keep tweaking things, I have experienced that many patients over time can get to a better place. Perfect? No. Ideal? No. But better. Less impact from the seizures, less disruption to life. And some of that is about focusing on specific goals. What can we tweak to try to just shorten those seizures that are most disruptive, or this type of seizure I dislike the most? And we're going to focus on that, try something, see if it helped, try something else, and keep working at it. And with that, I'd like to thank first the ICCRN team. This is our geographic picture for our 8 centers of excellence, plus Helen and Jenny and her team in Australia, that we're working on a bunch of outcome measures to help assess how we do in CDD and how we can affect change. These are pictures of all the investigators involved, and thank you to the NIH and NINDS for supporting our clinical trial readiness study that you'll hear a little bit more about tomorrow in a video. And most of all, a special thank you to all of you, to the patients and parents and siblings, Emma. And you guys really provide the meaning for why we do what we do, and you are the means by which we do it. We can't do this work without you. So thank you to ISCR, CDKL5 Canada, and Lulu Foundation. With that, I think I ate up a lot of our time. We were ahead of schedule, but I am happy to take some questions.
Dr. Demarest, can you see the questions there in the Q&A?
Yes, I can.
Okay, because you have quite a number of them, so feel free to answer as many as you can live, and then you can follow up with the balance offline if that's okay.
Sounds good. All right. Is an individual aware of their surroundings during an atonic seizure? Many atonic seizures are quite brief. So just a quick fall may last only a second or two. During that actual second or two, they're probably not aware of their surroundings. So if they're falling and getting injured or hitting something, if they're slumping, they're not probably aware of that impact, but they may regain awareness quickly afterwards. If it's a longer sort of atonic thing, which is less common, then during the actual seizure, they're not aware, but they may regain that awareness quickly afterwards. Let's see. I fell off the wagon. Good night. I'm just going to read in my head and then I'll try to answer. Yeah. So part of this is sort of how do you deal with different types of seizures and different medications? We have ideas as epilepsy docs about these types of medications are better for these types of seizures. Some of that holds true for CDD, but a lot of it doesn't. And so I have found that for particular patients, oftentimes when we think about, this is a tonic seizure, I want to target it with this medicine, that may or may not work in CDD. So you end up being stuck with trial and error. So how often should you sort of cycle through, try something new? I think this is a balancing act of, if you do everything at once, you don't know what's benefiting. So you need to be methodical and thoughtful about it. I think usually it depends on the stage that a family's in and how old the child is in many cases when we're sort of thinking about how quickly or rapidly do we want to change something. But oftentimes we're thinking about changing something every few months. So change something, give it time to see the either benefit or effect that it's having. If it's having a bad effect, you don't have to stick with it, obviously. Get off it. But you can kind of cycle through over a few months, tweak something. Sometimes tweaking just means changing dosing. Sometimes it means a whole new medication. There's discussion about other labels. Yes, there's a lot of other labels. Patients get labeled with Fragile X, with Rett syndrome, West syndrome, Lennox-Gastaut syndrome. How do we deal with the confusion associated with that? So Fragile X and Rett syndrome are specific genetic disorders and are not CDD. CDD used to be lumped in before they found the gene for it with Rett syndrome as a particular subtype of Rett syndrome. That's like 20 years ago when we didn't have the genetic knowledge we have now. That's really erroneous, and we need to just try to help get rid of that. West syndrome and Lennox-Gastaut syndrome can actually be a diagnosis along with CDKL5 deficiency disorder. West syndrome and Lennox-Gastaut syndrome describe the epilepsy, the seizures, and the EEG presentation for a patient. So it's really just descriptive. It doesn't say the why. CDD is the why. So you can have Lennox-Gastaut syndrome due to CDKL5 deficiency disorder. I think we're moving away from that because CDD is more specific than Lennox-Gastaut syndrome, but I think it's okay to sort of have that in the back of our mind because sometimes a medication that's available or a trial may be for Lennox-Gastaut syndrome, not CDD. And we just want to know that that's still an option. Yeah, so in some of the tables that I showed, not all of those studies had control groups. Many of those, whenever I said retrospective, looking back, they did not have a control group. We're just looking at, did they see a benefit with whatever they were trying as part of clinical care? Yeah, so meds are causing side effects, particularly as they were getting older, more sedated, not able to participate in activities and therapies. Yeah, we have to balance those side effects and the benefit from treatment. Part of that is if it's not helping, you don't need to be on it. Reduce the number of medications. I think it is important to be on some medications, but minimize them. Keep it down to 1 or 2 if you can, 3 at the most. 5, 6 medications generally are not helpful. I've seen rare exceptions. There's no blanket rules, but try to minimize them, make life easier, and reduce side effects. And yes, you should be talking about that with your neurologist. What age group for VNS? We sometimes do it as young as around 2 years of age, but we don't do it a lot younger than that. Any age older than that, it is a reasonable option to consider. We just don't like to do it in sort of the first year of life. Size of the device, things like that. We don't tend to do it that young. Let's see. And then sleep. Sleep wasn't the focus of my talk. Sleep's a big problem in CDD. Oftentimes there is a challenge of getting sleep regulated for these kiddos. Their brains are just struggling to kind of go through normal sleep-wake cycles. We have found without randomized control groups, good data, just observational, our experience, we've seen that there are medications that can help, and there's a whole slew of different medications that have been used to try to support better sleep patterns for CDD patients. And I could write a couple of those in the chat maybe, and sort of say, you need to discuss these with your doctor and work with them as you're thinking about it.